Well, hello, everyone. This is Dr. Isabelle Amigues, and I'm with Dr. Lauren Zimski, ophthalmologist and specialized in dry eyes. And as promised, last week, we talked about dry eyes and how we were diagnosing dry eyes and how we treat dry eyes. And when we discussed those episodes with Dr. Zimski, we were realizing that there's a lot of questions that are back and forth. So there are questions from a rheumatology word or a physician word that's not specialized in ophthalmology that I want to ask to Dr. Zimski. But on the same way, Dr. Zimski has questions for the rheumatologist that I am. And we thought that you would be interested in hearing this discussion so that you get a little bit more sense of the association between dry eyes and autoimmune disorder, as well as rheumatologic conditions. So basically, from now on, Dr. Zimski is interviewing me.
Well, thank you for the lovely introduction. And I have so many questions for you that I've had for so long. So I'm super excited to actually have you and be able to get some answers to my questions. So there is just a huge overlap between dry eye and rheumatologic disorders, particularly Sjogren syndrome, but we see them in all sorts of autoimmune disorders. We, definitely in rheumatoid arthritis, and in our world, thyroid eye disease is a huge autoimmune disease that affects the ocular surface, but it can be really hard for a non-rheumatologist to figure out which of my dry eye patients need to see a rheumatologist or potentially need lab work or blood work. How do I tease that out? And how do I get them, the help that they need? So I see a ton of dry eye patients, and obviously not all of them need to see a rheumatologist, and not all of them need blood work. So I have been searching and searching to try and figure out the best way to kind of tease out who needs blood work, who needs to potentially see a rheumatologist, and who do I just treat for their dry eye. And as far as the ophthalmic literature goes, there's been a ton of studies looking at, can you differentiate based on the eye exam, based on eye signs, based on the ocular surface? Can you differentiate who potentially has Sjogren's disease, they call Sjogren's dry eye versus non-Sjogren's dry eye? And the reality is, as far as the eye exam goes, there's just so much overlap. There's really nothing on my eye exam that is going to tell me that somebody has Sjogren's versus somebody has non-Sjogren's dry eye. And so I have a questionnaire. And I ask people questions. Do you have joint pain? Do you have excessive fatigue? The problem with that is almost everybody answers yes, or I get a lot of yeses. And so I'm still not really convinced that I know based on that who needs blood work. And so I've asked various ophthalmologists. I'm on an ocular surface disease group. How do you decide who you're going to do lab work on? And the answers are all over the place. So there are eye docs that say I do blood work on everybody, and I don't think that personally is a good approach, because I think that that's wasteful, and often, people are paying out of pocket for these tests. So I really want to pick your brain and figure out, how do I come up with a plan to determine who needs blood work, who potentially needs to see a rheumatologist? How do I screen out these patients?
Mm-hmm. Well, that's such a good question. So, so it's funny because I always discuss this, which is like one symptom doesn't make a disease, right? So you may have one symptom, but that doesn't mean that you have lupus or you have Sjogren or you have. For those who don't know, Sjogren is an autoimmune disorder that affects the salivary, so like salivary gland, as well as the tear glands, the lacrimal gland. And so it's going to cause dry mouth and dry eyes, but it can cause a lot of other symptoms that are, joint pain, can cause lung issues, and extreme fatigue, lymph nodes that are enlarged. It can actually be complicated by lymphoma, which is a certain type of cancer. So it is definitely something you want to make the diagnosis of Sjogren if there is Sjogren, because you want to prevent things from going south. Vast majority of time, Sjogren is very mild, but you want to make sure that it is indeed always mild. So I fully agree with you. I think, Dr. Zimski, that the fact that you don't, like, not all dry eyes are the same. I would say that it's kind of like dermatology for me. Like, just one rash doesn't make lupus, doesn't make Sjogren, doesn't make a rheumatologic disorder, but it's more like if there is two or more, then, like, yeah, maybe. And if someone has joint pain, and you can ask them if it's like, the three questions that we ask for everyone in terms of, like, is it an inflammatory arthritis, then I think that they absolutely need to see a rheumatologist. But if it's just fatigue, that's a little trickier.
So what are the three questions about joint pain that you always ask patients? Because I think I can incorporate this into my handout and into my questionnaire, and that would be super helpful.
Yeah, so an inflammatory arthritis is a joint pain that's worse in the morning. So as soon as you wake up, you have pain. That's associated with morning stiffness of more than 30 minutes. So they feel stiff, as if they needed some oil in their joints for at least 30 minutes. Sometimes it's like an hour, 2 hours more. So
it typically gets better. It starts out worse when you wake up and then gets better throughout the day.
Exactly. Okay. And another symptoms that there's like two other questions you can ask is exercise making the pain better? So that would be inflammatory. And then the last thing is that, is there swelling of the joints, and especially in the morning?
Okay. And so exercise will typically make it better.
Yeah. Okay. And so any yes on those questions, then you have the possibility of an inflammatory arthritis. And
that's great because everybody has like aches and pains, and really differentiating that I think would be really helpful.
Pain, and then those 4 questions, and anyone, like any question that says yes on this, you send to a rheumatologist. Now, again, right? So that's joint pain. Now, is there, like, so basically, if I were to look at your questionnaire and I were to think, okay, those are the patients I would like to see, I would think, if someone also has dry mouth, I want to see them, because dry eyes plus dry mouth becomes something that potentially could be Sjogren. Now, if they are on a medication that causes dry mouth and dry eyes,
and I have so many patients that are on either stimulants or antidepressants. I would say that is really hard to, that can be hard to tease out.
And so again, right? So if they have, so there's 2 options in there, right? Like, either you're like, well, they do have dry eyes and dry mouth, so I'm going to send them to a rheumatologist to make absolutely certain that this is not an autoimmune. Or you're like, okay, well, if we were to stop your, like, did this happen after you started your medication? That's like a pretty good question. Do you remember if this happened after you started medication? But the joint pain is not affected by the medication, so that's definitely something that would help you. And then the other symptoms, like shortness of breath, cough, rashes, like any skin rash, that would be like important. And then those are like the main one when it comes to Sjogren. So joint pain that's inflammatory, dry eyes, dry mouth, fever, lymph nodes, like swollen lymph nodes, and rashes. Those are, and then shortness of breath. That would be like, okay, well, we're maybe talking about a Sjogren patient. The other thing I would say is, you could we could argue that if you have someone that has dry eyes, dry mouth, since it's not just dry eyes, then you could do a blood work on them, and it is covered by insurance. Like, this is not a blood work that you're doing. It's not.
Sure.
It is.
The problem is, so many patients have high deductible plans these days that even if it's covered, it can still cost them.
It's not that expensive, honestly. Okay. Those blood work are not that expensive.
So question then, do you think it's better as a non-rheumatologist for me to do that blood work, or would you rather just see the patient and then decide what blood work they potentially need?
Well, in this era where it's so hard to see a rheumatologist. So for me, it's easy. If you're asking me, I will see the patient within a week or two, right?
Right.
But when it comes to the rheumatology world in insurance-based practice, they have like 3 to 6 month waiting time, and they also choose who they want.
That's been a deterrent for me also, because it's so hard to get patients in, and sometimes you're just not sure if they really need it or not.
Yeah, exactly. But it's not like, again, it's not an emergency. It's a quality of life issue.
Right.
So again, if you have a positive SSA and a positive SSB or a positive ANA with the dry eye, dry mouth, and a positive rheumatoid factor or low C4, all of those, then that, like, no one should stop you from seeing a patient. If you have an inflammatory arthritis, same thing, no one will ever stop you from sending those patients. So I think that that's actually quite important.
So I guess that kind of leads into one of my other big questions. We've always been taught in the ophthalmology world, with our limited knowledge of rheum, that those tests are often positive late in the disease course, and that having a negative test doesn't mean that you don't have Sjogren's.
Yes.
So that's another confusing point. That's another confusing thing. Like, how do you handle that?
So absolutely. So this is so important. And I keep saying this over and over again. The same way that a biologic, blood work doesn't make a diagnosis when it comes to rheumatology. So you can have a positive SSA, SSB and not have Sjogren. But also the same way you could have negative antibodies and still have the disease. So it's really an art of making a diagnosis, and you really need a rheumatologist and an MD or DO, but like someone that has actually done a fellowship in rheumatology. So that's a good question. So we know that usually antibodies come earlier than the presentation of the symptoms. Like in general, when you look at studies of lupus patients and rheumatoid arthritis patients, which are other type of autoimmune disorder, we know from veterans study, so the VA studies, that when they look at the blood work of recruits, they would actually get blood work regularly, and they could actually say, okay, well, the antibodies actually appeared before the disease appeared in the vast majority of time. And so technically with Sjogren.
So does that mean that somebody that's coming to see me that potentially has severe dry eye from Sjogren's would be more likely to have a positive antibody because they already have a presentation of the disease? Okay. Yeah. That's super helpful, because that's the other thing is I'm never quite sure how to interpret all that.
Yeah. So normally, if someone has dry eyes and we think that it's Sjogren, they should have SSA, SSB, or ANA, or rheumatoid factor, or like a low C4.
So it increases the probability that one of those
tests.
It's
all probability. So that's actually why I love rheumatology, and why some people find it so frustrating, is that it really is an art, and it's really like, look, you have symptoms that are consistent with Sjogren, and then we're going to look at your antibodies are consistent also with Sjogren. I've had patients where clearly they were super dry eyes, super dry mouth. All of the antibodies were negative, all of them. But then when you do the biopsy of the salivary gland, which is like the little bumps we feel in our lips, under our lips, it was typical of Sjogren. And so this is where we think that we don't know all of the antibodies of Sjogren. And I know earlier we were talking about the early Sjogren panel, which, in rheumatology, we use that panel more for research purposes than for diagnostic purposes. But again,
can you order it from a regular lab, or is it like a specialty?
Does it? Yeah. They do early Sjogren panel. I think what's so important is to realize that, and this is maybe the French in me, like the French trained doctor in me. In France, you do not need a label. So you do not need a diagnosis to treat patients. Whereas in the US, because insurance want to make sure that you're not fraud, I don't know really what the story is, but I think they want to make sure that you're treating the person with, something that's FDA approved. I don't know. I think it's regulatory, but I think it's mostly because they want to save money. But anyway.
I think it's because insurance companies don't want to spend money.
Yeah, exactly. And I do think that that's the case. But basically what it is that you have to have a label. This is something I had to come come to the resolution of, as a physician that trained fully in France and then in the US again, and I couldn't understand why patients as well as physicians needed a label all of the time, even when we were like, I'm not completely sure of what this is. And I want to stay open-minded because it may evolve. They were like, no, you need a label, you need a label. And then it took me a little bit of time to realize that it's because you need a label so that the insurance will cover the medication. So in France, the way we approach, like the way I was trained, is that sometimes you don't have a label. Sometimes it doesn't exactly behave the way that, it's not textbook.
The textbook says it's supposed to behave.
That said, you still want to treat the person. And so this is so important, right? Diagnostic criteria in general in rheumatology are for research purposes. And so then everyone is like, when the insurance company are asking us for a label, I think some people have thought that, oh, I'm putting a label, it has to fit the criteria of the classification, when really, actually, that's not the case. It has to fit the criteria for the classification if you're doing research studies, but like you're a doctor, and as a doctor, you have the right to say, I think this is that. And that allows you then to treat the patients in the appropriate way. So what I mean by that is that if a patient is behaving like Sjogren, so think about it, right? Now we know that not all Sjogren are seropositive, and they have like a positive ANA, a positive rheumatoid factor, or a positive SSB. We know that now. But 10 years ago, we did not know that. And 10 years ago, you had two schools. You had, I'm going to call it the French school. I'm not even sure if that's the case, but I'm going to pick this up, right? The French school, which would say, this patient is behaving like a patient with Sjogren. I'm going to treat them like Sjogren. And you had this other school of, I'm sorry, you do not fit the criteria. Please go and see someone else. and basically like leaving those patients like, what do I do, right? And so there's a lot of gaslighting in the medical community when it comes to Sjogren, because the
French way sounds much better.
Yeah, but
because the doctors actually get to make decisions and make treatment plans.
Yes, exactly. Well, but that's a very different, it's not perfect either, but it does explain, it's this expression of like, look, the doctors know, like we do what, I don't know, I did 17 years of studying, but like the vast majority of us does what, 11 years of studying. There's a reason why our medical training is so long, is that it's not black and white. It's not so easy. There's a reason why Google Medicine has not worked. And while we can use AI, it's not able yet to take over the role of the doctor. And so I think that that's really important to realize that the labeling of a condition in rheumatology may be, kind of a suspicion. It's like, I'm suspecting Sjogren. And I listen to my patients, like when they say, I think, I have dry mouth, I have dry eyes. Like, do you think it's Sjogren? I'm reading this online. And I'm like, well, let's look, what other symptoms do you have? And even if they have negative serologies, I think that it's always worth trying stuff, right? Like it's always worth trying.
So when do they get a biopsy?
Okay, so this is so cool for me, because it made me realize that I've changed my practice of medicine. So when I was a fellow in France, a resident in France in rheumatology, which is why I'm saying fellow, but basically any patients that would come through our door would get a lip biopsy. So I used to do lip biopsy in 5 seconds. Like it was really, really fast.
That's cool.
Yeah, very, very easy. And then we would get, that was sort of this extra amount of information for our patient. And then I came to the US and I cannot do biopsy because I'm not trained in the US to do the lip biopsy. And I'm like, come on.
Really?
Yeah, that's okay. Really. Because what it made me realize is that when you don't have access to something, you realize very easily that you don't necessarily need to have access to that. And so, we send our patients for lip biopsy to ENT. They can do it. It's usually very deep. So it's a little bit more invasive than what I had done when I was in France. But what I found is that it's very rare that it actually helps me. Most of the time, what happens is that you would want to know if you really wanted to make a certainty of a label. So what I mean by that is that if a patient just has dry eyes, dry mouth, there's not much you're going to offer, right? When it comes to the rheumatology word, you're not going to immunosuppress them like crazy. You may offer them Plaquenil if they have fatigue or if they have joint pain, in addition to the dry eyes and the dry mouth. So in this case, do I really need a biopsy? And so I always offer it to patients. I tell them, if you're positive, you don't need a biopsy. If you're like SSA, SSB positive, you don't need a biopsy. But like, let's say they are negative, right? And they have no serologies, and I'm not going to do a biopsy if the only thing they have is a dry eyes, dry mouth, and fatigue. Now, if they have lung involvement or nerve involvement, which can happen in Sjogren, and they are seronegative, and they have dry eyes, dry mouth, that is when I would be like, I'd like to have a biopsy, because I'm wondering if the lung issue you have is related. I'm wondering if the nerve issue you have is related. So it's really a case-by-case basis, but it's always like thinking, will it change my management to this patient, right? Yeah.
Well, that's great. That is super helpful, because I'm always wondering, who needs who needs this? But it sounds like, so let's say that somebody just really has, I see a lot of patients that have dry eye and dry mouth. Is that something that even if they had positive serology that you're going to necessarily treat, or is that something you just kind of watch over time?
I think, if they have so the thing that we have to remember is that while in the vast majority of time, Sjogren is mild, it's just dry eyes, dry mouth, it can actually affect the nerve, it can affect the lungs, it can affect the joint, it can affect your blood cells, and then it can cause a lymphoma, so it's a certain type of cancer. And so I want to see those patients, because you can prevent that from happening.
Yes.
And so if they have dry eyes, dry mouth, and you get to find that they have a positive SSA or SSB or rheumatoid factor or ANA, I do think that they need to be evaluated by a rheumatologist, even if it's a once a year thing. Again, like whatever is preventable, and that's what's cool about this. Yeah.
No, that's great. That is super helpful for me, because I'm always kind of questioning, does this person need to see a rheumatologist? Does this person need blood work? And this really helps to just kind of clear things up, and specific questions that I can ask to really, provide better care.
Yeah. Okay. So I want to say, I think I'm going to just add this one thing, which is there is Sjogren, that's primary. And then there is secondary Sjogren. And so when you were mentioning rheumatoid arthritis, lupus last week, and that we were talking about that rheumatoid arthritis can have this, that lupus can have this, usually what happens is that they have secondary Sjogren. And so it does add this element of, yes, they have rheumatoid arthritis and they have lupus, but they also have this secondary Sjogren that I also need to take care of, because again, if it's secondary, it can also cause all of the complication we were mentioning about the primary one. So I just wanted to just add this because, again, rheumatology is this very nebulous and artsy form of medicine, which I love. Yeah.
Well, that has been super helpful, and I'm definitely going to incorporate this into my practice. And I've been wanting to ask you these questions for so long, so I'm super excited that we got to do this today.
Yeah, no, absolutely. So great. Since you're on the podcast, I want you to let us know again the name of your ophthalmology practice where patients can come and see you. We are going to have all of this in the notes, of course, but if you don't mind just sharing the name of your practice again, right?
So I am in solo practice, so it's just Lauren Zimski, MD, and you can find my website, LaurenZimskiMD.com. And I am on social media too, both Facebook and Instagram, and I'm trying to embrace it.
Not easy. Well, so grateful to have had you twice on this podcast, Dr. Zimski. It's been such a pleasure, and we will continue this conversation, and I'm sure you'll come back for take two.
It was so great.
Yeah. Bye.